Okay, wanted to thank the American Migraine Foundation for having me here. I hope that you guys can hear me. I'm sure somebody will let me know. My name is Shivang Joshi. I currently work at the DENT Neurologic Insitute. I'm a headache specialist neurologist there. And my background is also I have a master's in public health. I also have a pharmacy degree as well. Currently in the headache practice. I'm also an associate professor of clinical pharmacy at the University of Buffalo School of Pharmacy. Okay, so, all right, I'm seeing the comments. Okay, good. Now I'm seeing the comments. Thank you, Susan, for confirming that you can hear me really well. I appreciate that. So before I begin, so the title of today's talk is Headache Pharmacology 101 for patients and the do's and don'ts. So I particularly like this topic because I like teaching. I like teaching my patients as well too. And I have a passion about pharmacology as well too. I just want to read out a quick disclaimer before I begin. So the content of this webcast are for general informational purposes only. They do not constitute medical or legal advice and is not intended to be a substitute for professional medical advice. Diagnosis or treatment. Always seek advice of a physician or your physician regarding any specific medical questions that you may have. And so I'm going to begin. So let's backtrack to a little bit of history. So the history of treatment. If you go way back to the caveman ages and even a little bit after that, people used to treat medically with supernatural means. They would use incantations, and then later on in the Neolithic age, they would actually do something called trepanation. And basically, if someone had a headache, they would take an instrument, a primitive instrument, and take out a part of their skull. And those are some of the primitive things. As the years progressed, there's something called the Eber's Papyrus, one of the oldest medical texts, can date back to 1200 BC. And they found pictures of these clay alligators with herbs in them placed on patients' heads in an attempt to alleviate some of their headaches. Later on, as the years progress, you have Galen, Hippocrates. They attribute some of these headaches to vapors coming from the stomach. In 1664, it was attributed to the vascular theory that was first theorized. 1884, W.H. Thompson first introduced ergots, but they had some side effects resulting in massive vasoconstriction and gangrene. So since then, the ergots have been modified, and there was the first sort of start to the development of true headache treatment medications or pharmacology was development of ergotamine a while ago. And throughout the ages, there's been a back and forth of, is it a vascular theory? Is it a neurogenic theory? Is it neurovascular? Back and forth. I think the current most understanding is that it has to do with neural inflammation. Okay, so I'm going to begin with some basic definitions, pharmacology definitions. Okay, I see more people logging in. I just want to make sure. Okay, that you guys can still hear me. And all right, so some basic definitions of what's going to pertain to our talk today. So pharmacology refers to the action of chemicals on biological systems. Receptor is when a drug binds to a receptor, it does this to bring about functional changes to a system. A half-life, sometimes you might have your physicians talk about half-life of a medication. What that refers to is the amount of time it takes for the concentration of the drug in the blood to decrease by 50%. Another term you should be familiar with is bioavailability. And bioavailability refers to the percentage of drugs that reaches the circulation, okay? All right, so today what we're going to talk about is acute and preventative medications. We're going to talk about different routes. This is not meant to be extensive. Obviously, we only have about 20 minutes and 10 minutes to discuss questions. So this is not meant to be exhaustive. I apologize if I miss a molecule or a chemical, but I thought I would pick out some of the salient features that I generally discuss with my patients in the office. So I know that there are some people that are logging in now. Just wanted to reintroduce myself. My name is Dr. Shivang Joshi. I currently work at the DENT. I'm a headache specialist. I'm also a trained pharmacist. And today we're talking about headache pharmacology 101 for patients, the do's and don'ts. Now, let's talk about different routes of delivery. There are oral routes, there are nasal routes, and there are subcutaneous routes, which is under the skin. And in terms of treatments, these would be treatments outside of the office. Also, things available include intramuscular injections as well as IV medications. And these are all different routes of triptans. Now, triptans are a class of medications that you guys are probably familiar with. It was one of the sort of the gold standard of medications that came out to treat acute migraine attacks. The classic triptan is sumatriptan. It goes by a brand name of Imitrex. Some of you may be more familiar with that term, but sumatriptan, the do's of this medication is that you should take at the onset, and it generally works better within the first 20 minutes of your migraine attack. The sooner you take it, the better off you are in response. You're allowed to repeat it one more time in 2 hours, and that's about it. The don'ts are, do not take more than 2 doses in over a 24-hour period. And in general, to avoid something called medication overuse, which I'm going to touch upon later on, you also don't want to take it more than 2 days out of the month as well, too. Some of the typical side effects in patients who are triptan naive, and when I refer to that is patients who've never taken a triptan before, they may want to start off with half the dose initially to see how they react. You may get a flush sensation, a chest tightness, palpitation, or a flush sensation, or sometimes a little jaw tightness. So when that happens, wouldn't be alarmed. Sometimes that can be not related to a cardiac. It's a non-cardiac response. It might be that you might be too sensitive. Either the symptoms will not occur again, or you would need to be changed to a different medication instead of an oral sumatriptan tablet. Now, we talked about some of the basic vocabulary words, half-life. Now, the triptans are available in different types as well, too. And some of the differences include how rapidly they get absorbed within the stomach. For example, sumatriptan has some of the lowest oral bioavailability if you take a tablet by mouth. Medications that have a longer half-life may be more advantageous to take, for example, someone who has menstrual migraine. So medications like naratriptan has a long half-life, longer half-life than the typical triptans, and even longer than that, medications like provatriptan has an even longer half-life. These medications are ideal to use as a preventative method 2 days before your menstruation, or typically around your menstruation, to prevent those headaches from even occurring. So that's one thing to consider when you talk about different triptans. When you treat your headaches acutely, sometimes your physician may also pair them with something called Nsaids, which are non-steroidal anti-inflammatory medications. They can also pair them with anti-nausea medications. Now, there are different anti-nausea medications. The classic one is ondansetron, which is primarily used to treat nausea. There are other medications called metoclopropamide, which goes by the brand name of Reglan, and then also compazine and prochlorperazine, or Phenergan, which are other anti-nausea medications that sometimes they use in the emergency rooms. Those medications affect when I mentioned the receptor, so these medications affect the dopamine receptor. Sometimes they're associated with rare side effects called restlessness. Sometimes they're associated with a neck muscle spasm. If that occurs, you would probably want to take a Benadryl or notify your physician. So those are more rare side effects that take place. So physician may want to combine the acute triptan with an anti-inflammatory medicine or an anti-nausea medication for acute treatment. Continuing on with triptans, some of the other things to be cautious about with the triptans that are available currently on the market as a class, you want to be careful if you have uncontrolled hypertension. That is a contraindication. You also want to be careful if you have peripheral vascular disease and you do not want to take, within a certain time period, 24 to 48 hours of using dihydroergotamine. Okay? Now, there is something called serotonin syndrome. You may have encountered this when you went to fill your prescription at the pharmacy and you were prescribed a triptan, oral triptan medication or any triptan medication, and the pharmacist saw that you were on a serotonin reuptake inhibitor or an SSRI, such as Prozac or Zoloft or SSI in general, and told you that there was a potential for serotonin syndrome. Now, theoretically, there is a rare potential. However, using monotherapy of a triptan, and if you're on one antidepressant medication, there's a very, very low chance of something called serotonin syndrome occurring. There's a consensus report out there from the American Headache Foundation, and you can look at their website for more detailed explanation. But just to bring it to your attention, you should know what serotonin syndrome is. It can occur between minutes to hours of having of taking a triptan with an SSRI. And once again, I want to point out this is very rare, not a common finding. These symptoms may include agitation, hallucination, increase in heart rate, your blood pressure going up or down, increase in temperature, restlessness, as well as nausea, vomiting, diarrhea, and some incoordination. Now, there are other non-triptan medications that are used by patients. Some of them include anti-inflammatory medications. There is ketorolac, which is available as a nasal spray. You want to make sure you use as directed. Do not take additional Nsaids when you're taking these medications, or one Nsaid in general. There's also an oral solution for potassium, oral diclofenac potassium solution. The do's for this include you do want to take with 2 ounces of water. You do not want to take with anything else that's not water, okay? Including fruity juices or things like that. What you do not also want to do with this oral solution for diclofenac is take the powder, put it in your mouth, and then chug some liquid after that. Not advisable. Now, other over-the-counter medications that patients may take include Excedrin, which is a combination of Tylenol, aspirin, and caffeine. What you want to do is be careful not to take more than 2 days out of the month. We generally do not feel that this is very specific treating a migraine. However, there are some patients who do benefit from it, and that's their only choice. And what I would have to say is if you limit it to not more than 2 days out of the week, it's probably okay, but it wouldn't be the first thing to take for the treatment of your migraine. So you have to be careful with the caffeine and the Excedrin can contribute to something called rebound headache. And a rebound headache or medication overuse headache refers to the more you take a medication, sometimes it can cause more headaches. Okay. Now we're going to talk about preventative medications. Now, the American Headache Society and the American Academy of Neurology came up with some guidelines where they classified preventative medications based on efficacy. When I say efficacy, what I mean by is effectiveness based on randomized double-blind placebo-controlled clinical trials. It's a fancy word for a very scientific study. And they categorize them into between level A, level B, and level C. I'm going to focus on just some of the few ones that are found in level A and B. There are other guidelines that are available, and the other guidelines, such as the Canadian guidelines, also incorporate adverse events or adverse reaction profile in taking into consideration the weighing of the medication as A, B, or C. Okay? So let's look at one medication in particular, Depakote. Now, Depakote or valproic acid, some of the do's with this medication include taking it on time. You want to make sure you hydrate really well on this. You could take it with food if it upsets your stomach. The sprinkle capsules that are available, you want to make sure that you do not, you can open them up. You don't want to take the extended release formulations and crush them or chew them. You do not want to take this with alcohol. You do not want to take this during pregnancy or if you are planning to get pregnant because of the potential for fetal malformations. Okay. Just looking through these comments here. Okay. And some of the things to watch out for include weight gain, jaundice, or dark urine. If you have these, then you may want to discuss that with your physician. Another medication is Venlafaxine. Venlafaxine belongs to a type of serotonin and norepinephrine medications. It's an antidepressant medication. It's also used for anxiety disorders as well. Sometimes this can cause blood pressure changes, something called orthostatic hypotension. It may even cause hypertension. So you want to monitor your blood pressure when you're on this medication. If you also have narrow angle glaucoma, you want to be careful with this medication as well. And they do have extended release formulation, which you do not want to crush. Okay, I'm seeing a bunch of comments here. I just want to make sure you guys can still hear me. I'm not clearly seeing any questions here. Oh, okay, I am seeing some. I will try to address these shortly, but I really want to get through some of these salient topics and points that I want to discuss. So the next molecule I want to discuss is topiramate. Topiramate goes by the brand name of Topamax. It's available as a generic. It's also available as a branded in 2 different extended release formulations. Very important. I tell all of my patients, make sure you drink a lot of water and hydrate on topiramate. You could also potentially increase your potassium intake on this too to minimize some of the adverse reactions. Quite often patients complain of paresthesias. It may go away over a period of time. Hydrate to minimize the risk of that happening as well. Patients may also complain of cognitive effects, and this may also go away over a period of time. If this occurs during the day, generally we can dose this medication at bedtime. If it still occurs, sometimes some patients benefit from an extended release formulation. Now, if you have glaucoma, in particular angle closure glaucoma, you should not take this molecule of topiramate. Okay? There's a difference between angle closure and open angle glaucoma. Open angle glaucoma is more of the common type of glaucoma that you would see. Children in general, remember, topiramate is also indicated for seizures, and it's used by younger patients as well. Topiramate can cause dehydration, especially in children more so. So you have to be really cautious. Now, I mentioned a few adverse events. It can also cause decreased appetite, so make sure you do not skip any meals, because remember, that's another trigger, potential trigger for migraines in some patients. If you have osteoporosis, you want to make sure you're monitoring that, because there may be some effects on the bones if you do have osteoporosis. It's very important to hydrate again. Remember, topiramate, hydrate, hydrate, hydrate. Some patients, topiramate may cause some alkalinization of the urine. And basically what that means is it makes the urine basic versus acidic. And when the urine becomes basic, it's culture media for bacteria to grow, and you may rarely develop urinary tract infections. Once again, these are not the common things that may occur, but things just to be aware of. So hydration is going to be key again. Now, some of these adverse effects can be mitigated through hydration, modifying the dosages, taking a different formulation, or taking it at bedtime. One thing that I do caution against is that if you do have increased emotionality or mood changes, it probably is a good time to call your physician and discontinue the medication or taper off the medication. So you do want to not rapidly, you don't want to just discontinue very rapidly. You want to titrate off. You want to be cautious if you're planning on becoming pregnant. And those patients who are diabetic or that are taking metformin, metformin is a medication used to reduce blood sugar. It's also used for other indications such as polycystic ovarian syndrome, et cetera, and some other syndromes called NASH. I'm not going to get into that. But metformin by itself has a very low percentage of chance of causing something called metabolic acidosis. Basically what that means is it makes your blood acidic. If you do take topiramate, you have to be cautious because the combination of those two can make your blood even more acidic and cause some respiratory symptoms as well. So you may want to have some monitoring of your kidney function if you're on both of those medications. Okay, so moving on to the next class of medications, I'm going to talk about beta blockers. Now, beta blockers are a group of medications that are blood pressure medications. They have non-specific ones, they have or selective ones. There's beta 1 and beta 2. And these are receptors, again, that I mentioned what a receptor was. And the receptors are found in the lungs, they're found in the heart, they're also found in the smooth muscles and throughout the body as well. What you want to make sure is that if your physician starts you on a non-specific beta blocker, such as propranolol or Inderal, which is the branded name, and if you have asthma, you want to be cautious and alert your physician, because sometimes it can aggravate symptoms of asthma on a non-specific beta blocker. Beta blockers can sometimes cause a little bit of insomnia if you take it at bedtime. Okay? If you do take it at bedtime, and if you're taking a higher dose, if you're an athlete, if you're exercising a lot in the morning, if you're doing a marathon or a lot of intense aerobic activity, it sometimes can make it a little bit of a struggle to do that, because it does decrease your heart rate as well too. So if you're feeling sluggish when you're doing these extraneous exercises or running, you may want to try to change the dosing around and discuss that with your physician. Rarely at higher doses, propranolol can cause weight gain as well. You do not want to stop propranolol abruptly. It's something that should be tapered off as well. If some of you develop any kind of cold fingertips or cold limbs when you take propranolol, it may be an indication that you have something called Raynaud's disorder. Now, Raynaud's disorder has to do with cold intolerance, and your blood vessels in the extremities are very sensitive to cold temperatures and will turn blue. And sometimes adding propranolol, because it affects a certain receptor versus another receptor, can exacerbate this. So that's something to be aware of as well too. Now, for the diabetic patients, one thing to be aware of is that if your sugar goes very low, especially if you're on insulin, sometimes if you're on propranolol, it might mask the symptoms of hypoglycemia. So you may not know that your sugar is actually low, and you should generally avoid using a beta blocker if you have a habit of having low blood sugars. Okay. Moving on to a next class of medications, I'm going to talk about something called tricyclic antidepressants or amitriptyline. These are medications that have been used in the past for depression. There are a lot of new medications that are used for depression, but amitriptyline is still used, or nortriptyline is still used for the treatment of headaches, neck muscle tension, and other indications. Now, it goes by the brand name of Elavil. Remember that there's also nortriptyline as well, which goes by the brand name of Pamelor. And the difference is that the chemical structure of the amitriptyline and the nortriptyline is a little bit different. The chemical structure of the amitriptyline allows it to be travel into the brain a little bit better versus the nortriptyline. That's why it's associated with more sedation. So both of these medications can potentially cause sedation, dry mouth, urinary retention, and that's referred to as something called anticholinergic effect. So patients that are older, that have urinary retention problems, if you give these type of medications, it can cause a dry mouth, which can lead to dental caries as well, and it can cause urinary retention, which can lead to urinary tract infections, so you have to be careful as well too. Some patients may also experience flu-like symptoms and also decreased libido on these medications as well. Other things to watch out for: increased heart rate. I've actually seen some few patients who've also had increased blood pressure readings as well. It may affect your weight at higher doses. It generally improves mood, but some people can have paradoxical mood effects or paradoxical insomnia as well, causing either insomnia or more increased agitation. At that point, we would have to discontinue the medication. In general, you do want to tell your physician, if you're on multiple other antidepressant medications, you do want to let them know that. You do want to tell your headache provider if you have a diagnosis of bipolar disorder. Sometimes these medications can exacerbate this, especially in the first 2 weeks. You have to be closely monitored. If you have hypomania, sometimes antidepressants can activate the hypomania. You may not know. That's why the first time you initiate antidepressant or SSRI medication, you want to monitor the patient or advise them to be aware of these mood side effects. Now, what you don't want to do with this medication is discontinue it rapidly. You do want to taper off it. You should be cautious that it may also affect you if you have glaucoma. For women who are breastfeeding, it is secreted in breast milk. You do want to be careful. There's a great app. It's free. You should download it. It's called LactMed, LACTMED. It allows you to look up medications and see what the breast milk data is available. So it's one thing that I always have my students also do. And if you do take this medication, sometimes if you get up too rapidly, you might get some dizziness, so you want to be careful. The last group of preventative medications that are oral I would want to talk about is ACE inhibitors. ACE stands for angiotensin converting enzymes. The previous generations were ACE inhibitors. The new generations are something called ARBs, or angiotensin receptor blockers, just a fancy word for blocking a part of the kidney, okay? What you want to be careful is that some patients who rarely are sensitive to this class of medications may have something called angioedema or swelling of the mouth, okay? And it can potentially cause dizziness. It is secreted by the renal system, so if you have renal dysfunction, you may want a physician know. If you are lithium, you want to be careful. And if you're taking a lot of potassium supplementations, this class of medications actually generally tends to retain potassium in the body. So too little potassium can cause arrhythmias, too much potassium can cause arrhythmias too, so you want to be aware of that. Now, I'm sure you guys will ask me, and I'll tell you just ahead of time, there are other newer classes of medications. There are other medications that have been used for treatment of chronic migraines, including Botulinum Toxin. And you want to make sure that you should alert your physician if you are planning on getting pregnant or become pregnant with the newer CGRP monoclonal antibodies. Injection site reaction may occur. And you also want to alert your physician if you're planning on becoming pregnant or do become pregnant as well. There's limited data available for both of these. I'm not going to go too much in depth into those medications. Things to consider: if you do take vitamin B2 or riboflavin, you should also hydrate. Rarely I've seen it cause urinary tract issues. And you should take it twice a day. Do not take all 400 in the morning. As I mentioned one of the terms earlier on, it has a very short half-life, so that's the reason why you want to take it twice a day. It's out of your system very quickly. If you do take magnesium, in particular, I like to dose magnesium oxide, 400 milligrams twice a day. There are other formulations available. You can sometimes get GI effects. You can mitigate those by either taking it with food, taking it once a day, and then increase it to twice a day after that. And what you want to do is, what you don't want to do is, if you take thyroid medications such as levothyroxine, you want to space your thyroid medication apart several hours apart. Most of you probably take levothyroxine first thing in the morning, empty stomach, with a full glass of water. And you generally take your other medications a couple hours later, and that's okay. There's a binding effect with the magnesium and other aluminum or magnesium salts, which would make the levothyroxine less effective binding. And as far as other vitamins, butterbur is now generally recommended. It had to do with some liver toxicities that took place, and it had to do with some of the formulations, and it's really hard to determine which formulation is the correct formulation and the processing and where it came from. In Germany, they have it a little bit down to a science with the butterbur in particular, but you have to be really careful if you're going to be using that due to liver toxicity.